Welcome to Inside Urgent Care, the podcast that shares stories from within, you guessed it, the side of healthcare we all know and love, urgent care. This is the space for you to hear inside perspectives and authentic conversations from those working in the space. Thank you for being here, and let's get into it.
Hello, and welcome back to Inside Urgent Care, where we share inside stories and perspectives from those working in urgent care. I'm Samantha Wolf with the Urgent Care Association, and we're happy to have you back with us. Today's episode is patient-focused and trauma-informed care, and we are joined by Meg Phillips, family nurse practitioner at Mass General Brigham Urgent Care and faculty at MGH Institute of Health Professions in the School of Nursing and at Endicott College School of Nursing. Meg has extensive experience within urgent care and the evolving technology of delivering on-demand healthcare. Welcome to the podcast, and thank you so much for being here.
It's my pleasure. Thanks so much for having me, Sam. I'm really excited to have the opportunity to discuss patient-centered and trauma-informed care and urgent care today.
So happy to have you here. Can you please give us a little bit of your background and path within urgent care?
Sure. So years ago, I was a veterinary technician for a couple decades, actually, and ultimately decided that I wanted to move into human healthcare and to be a healthcare provider and moving away from kind of the vet tech, more supporting role. So ultimately, I completed my family nurse practitioner studies. I started work in a correctional setting while doing some further training in urgent care skills and procedures and continuing education. And within several months of graduating, landed my first role in urgent care, which is my Mass General Brigham urgent care role. Within that role, I have had the opportunity to be full-time as well as per diem. I've had the opportunity to teach colleagues, students, new hires, to precept, to mentor. And it's been a fantastic trip. I'm doing more virtual urgent care these days, which I enjoy very much as well.
That's great. Thank you, Meg. So, getting into it, especially, your current role here, what would you consider patient-focused care? How would you define that?
Yeah, good question. So, patient focused care is sometimes also called patient centered care. And this is essentially a model of care that is not only inclusive of, but really highlighting patients' psychosocial, financial, cultural, and otherwise personal or person focused perspectives when tailoring care plans, right? And so, what this means is that we're looking at a departure from the traditional doctor patient or patriarchal medical model in which the provider is making all of the decisions and dictating care to a patient, and in which the patient's perspective and agenda were not as important as that of the provider. Okay, and so this is a switch where we are also really considering the patient's perspective, the patient's agenda, the patient's goals, the patient's lifestyle, the patient's abilities, the patient's own intrinsic motivations, right? And we see that the data bears out that there are a lot of benefits linked to patient-centered care. So we see that there's more trust between patients and their providers. We're having better patient and provider relationships. And all told, we're having better health outcomes when we're using this patient-centered care. For example, the Journal of Family Practice published some research that found that patient-centered care resulted in better recovery from discomfort and concerns, better emotional health down the line, and fewer diagnostic tests and referrals, which can decrease burden of care, stress, and cost for patients. There are also a number of studies that have found that patient-centered care can really be a big motivator for preventative care. And so essentially this can promote patients to return for their annual physicals, vaccines, and other preventative care, which can improve patient outcomes down the line. Additionally, the New England Journal of Medicine Catalyst explained that this model of care can also lead to improved patient satisfaction, as well as reduced expenses overall.
So helpful from a lot of different perspectives.
Absolutely.
Going back to you and your role, how does your role as an NP provide you with a unique perspective within urgent care?
Hmm. For me, being a nurse practitioner is very much an honor. This is something that I started to feel even when I started my nurse practitioner program. I remember the very first day of orientation, my faculty advisor sat down with a bunch of us and talked about how being a nurse is the most trusted profession and the most honored profession, and that we will be amazed at the level of trust that people put in us. And that's been my experience from day one in the clinical setting. Our patients put a ton of trust, a ton of faith in us. Typically in urgent care, we're going to be strangers to them, although there are some folks who, will utilize a facility regularly for urgent care. Most of the time when we're seeing people, it's at a really hard time, if not one of the most difficult times of their lives. They come to us scared, they're in pain, they're worried for themselves or their child or their parent or their spouse. They're dealing with competing obligations for their parent who needs to go to the emergency room now and their four kids that are at home and their job. People come into us bleeding, broken, and we're just so well positioned to connect meaningfully with and really meaningfully support these patients. If we just take an extra moment to really center ourselves, be mindful and present, we're able to form these really incredible relationships with our patients. And it's really humbling. And I take it on as an awesome responsibility every day. I'm very honored to be a nurse practitioner in this role.
Yeah, thank you for sharing that. That is a unique perspective. All clinicians serve an important role in urgent care, but I'm sure there are kind of specificities of interactions within the different professions as well.
Absolutely.
I know you're also passionate about trauma-informed care. So can you please provide us with maybe first, let's start with a kind of a basic definition or high-level overview of trauma-informed care and what that means?
Yeah, absolutely. I am very passionate about trauma-informed care. I love trauma-informed care. So, trauma-informed care is this term and framework that was put forth by SAMHSA, which is the Substance Abuse and Mental Health Services Administration here in the US. Essentially, trauma-informed care has two different components. There's a macro level component, which is kind of an organizational, top-down, overall policies, procedures, environmental approach. And then there's the one-on-one clinical patient interaction approach that clinicians and support staff and nurses can take with the patients to make very small changes that make a very big difference in patient outcomes, patient retention rates, patient compliance with care plans, and patients' satisfaction with their care and their care plans. And so the big overview is that SAMHSA has developed four R's to kind of describe this framework of trauma-informed care. And those four R's are the following: realizing, and this means that we are realizing that trauma exists and affects people and groups. The second R is recognizing, and this is recognizing what the signs of trauma are. The third is responding, and this means responding with a trauma appropriate system. So making sure we have things in place on the one-to-one clinical level, but also the larger organizational level to respond to trauma. And then number four is resisting, and that's resisting re-traumatization of the patient or client. And so again, all of these can really be addressed both on a one-on-one basis, but also from that top-down approach. And SAMHSA really advocates that both are addressed because to address one or the other is an incomplete response.
What might trauma-informed care look like in an urgent care setting from that top-down organizational approach?
For example, a group may decide that as an organization, we no longer want to have patients be asked to disrobe before meeting with the provider, even though it may save time. The patient may prefer it in some cases. The staff may prefer it because it's more efficient in some cases. It's really not trauma informed to ask people to take their clothes off before they've met the patient, the person who's going to be treating them. Right. So this is placing the patient in a very vulnerable position to be asked to take off their clothing. They haven't even met the person delivering their care yet today, right? So you can imagine how that would feel to most people, even if they don't have any trauma history, let alone if someone does have a trauma history, to be told to take off some of their clothes before they've even met the person that's going to be caring for them. That can be very traumatizing. Other things that you can think about are things like making sure that the furniture, environment, temperature of the waiting room and the exam rooms are comfortable, are calming, are inviting, right? Not having a lot of loud monitors going off, a lot of loud overhead announcements, having the temperature in the clinic be comfortable, having TV or phone chargers in the waiting room so that clients can continue to either keep up with things they're needing to do in their own life or have some mode of entertainment for the endless waits, right? So things like this are things that we can do from kind of a top-down approach.
That's a great overview. Thank you, Meg. Then when we talk about the one-on-one clinical approach, how does that look when you're approaching trauma-informed care?
Yeah, this is a great question. And I definitely have a lot of passion for this part of the conversation about trauma-informed care. So there are lots and lots and lots of little pearls and tidbits, and we can talk more about those later on if you like. But the overarching kind of trauma-informed care clinical approach really means taking a universal precautions approach to trauma-informed care. So in medicine, when we think about standard precautions, we're really talking about taking the same precautions with every patient every time. Okay. And so what this means is if we'll be exposed to blood and body fluids, that we're going to wear gloves. Whether our patient has any contagious disease or not, we're going to wear gloves for all of our patients if we're exposed to these fluids. In the same way, we can say that trauma-informed care requires a universal precautions approach, meaning that we approach all patients in the same way, regardless of whether we know that they have trauma or not. And so, what is this way that we're approaching them? Well, we want to make sure that we are using open-ended questions. We are using patient-centered communication. We're keeping the locus of control with our patients at all times. We're making sure that our patients know that they have autonomy. They have freedom of choice over their own healthcare. Okay. We're also going to be diligent about our own self-care and watching for signs of burnout and vicarious trauma. And we're going to make small changes that can increase patient comfort, well-being, and control that will help to reduce re-traumatization. So every time we are engaging with a patient, we're introducing ourselves and our role and describing what that means in this situation. We're using the patient's preferred, also known as correct, name and pronouns every time. We're using opening, non-threatened body language. This next point is really, really important. This is endorsed by many, many major healthcare organizations. We have to be acknowledging and addressing intersectionality, which is essentially the way that our different identities impact each other, and the effects of interpersonal and structural racism and other forms of violence on health. This is something that it's really important for us to acknowledge and address with our patients. It's a very important part of trauma-informed care and patient-centered care. Another major tenet is that we want to do a history and discussion with our patient fully clothed. We always want to explain what's going to happen before it happens. We never tell a patient to just relax. And again, we're maintaining that shared agenda. We're offering choices. we're reaffirming that the locus of control is with our patient at all times.
I think that's really important to keep in mind because when you are a patient, you are defaulting to this medical professional and you can feel like you're placing control in their hands outside of yourself. So it's really important to make patients feel like they're still in control of themselves and their body.
Absolutely. There is very much an inherent power differential between provider and patient, as much as we don't want it to be there, don't like that it's there. And so, these are steps that we can take to try to mitigate that and close that gap.
Yeah. And I know you provided some examples, but do you have any more specifics of, pearls or specific things that clinicians could enact today?
I do. I have so many, Sam. Thanks for asking. Um, So a lot of these changes, as I said, are really teeny, teeny, tiny things you can do starting today to change practice. They're small things like changing the way that we speak about things. For example, many healthcare providers and staff will use the phrase "for me." Hop up onto the table for me, raise your arms for me, jump up and down for me. If we take out the for me, we don't lose anything. The point of our request or command has still come across. And taking out the for me can help to remove some of that power differential. Our patient is not doing anything for us. They are doing something in service of their own health, right? It's not for us. So when we take that away, we don't lose anything. And we're actually maybe gaining quite a bit.
That's a great point.
Yeah, it's such a little change, and that's the cool thing about trauma-informed care is that we can make all of these just little teeny tiny changes and they can make such a big difference.
Yeah.
Other things that we think about are the ways that we're speaking about anatomy or about our surroundings. So, for example, we don't want to call an exam table a bed. We don't want to call a drape a sheet. We don't want to call a drape a nightgown or something like this. And this is because we want to take away any connotation of being in bed, laying down in pajamas or a nightgown, things like this. We want to take it away from a bed. A bed can be a sexual place or a traumatic place. And we don't want that involved at all here. Other things we can think about are working with our patients to find the least invasive and least traumatic way of doing things. So let's say, for example, we have a patient who is very uncomfortable with allowing a provider to insert a vaginal speculum for a vaginal exam. But that same patient may be more comfortable after talking things out, looking at a speculum, touching a speculum, holding a speculum, with the idea of self-insertion of a speculum for a vaginal exam. So it's really kind of trying to work with these small changes to meet people where they are to try to get their goals met.
Yeah, that makes total sense because everybody's coming from a different background, different perspective, and taking that into account will go a long way, I can imagine.
Absolutely.
So we talked about the specifics of how you can implement trauma-informed care, but let's bring it back to why we're doing these things in the first place. So why is trauma-informed care so important?
Oh, great question. And this is really kind of the crux of it, I think. Um, so trauma is ubiquitous, it is everywhere. We are over the last decade and a half or so starting to learn a lot more about something called adverse childhood experiences or ACEs. And so these are experiences that children have in childhood that have an additive effect or a cumulative effect with a dose response curve. So essentially what this means is the more adverse childhood experiences a person has, the more likely they are to have certain poor health outcomes. And so adverse childhood experiences can include abuse, neglect, and various forms of household dysfunction, including things like separation, substance use, mental health issues in the house, incarceration in the house, or violence in the house. We know that 2/3 of the US population reports that they have at least one ACE. And we know that about 17% of the US population reports four or more ACEs. We know that when people get to 4 or more ACEs, they are much more likely to have suicide attempts, 14 times the rate. They are 4.5 times as likely to develop depression, 11 times as likely to develop IV drug use. And so the question becomes, well, what's happening here? How does this happen? And a full description of this is really out of the scope of this podcast, but essentially we have this idea of toxic stress or constant revving of a car engine, right? And so we can think about ACEs, trauma, systemic stressors like racism, homophobia, transphobia, xenophobia, any of these things, and many, many other isms and phobias that are essentially just like slamming down the accelerator of your car for days at a time, right? Your body's just in overdrive all the time. This really takes a toll on the psyche and it takes a toll physically, right? And so then we start to see that people who are carrying around past trauma may get a couple of minor inconveniences thrown in on top of that. Say, for example, that they have to wait for 2 hours at the urgent care, which granted, no one wants to wait, and that's a bummer. But all told, 2 hours is probably not the biggest inconvenience on the planet, right? But a person may be more prone to react very highly to the inconvenience of a 2 hour wait if they're dealing with past trauma, on top of systemic racism, on top of the stress of the COVID-19 pandemic. And so the goal is really to switch the lens from asking, what's wrong with you, right? When people are having big reactions, to what happened to you and how can I support you in this?
Yeah, that makes total sense. Look at why this is happening. Yeah. So that's one piece of the patient experience. So I want to bring it back here too to how have you seen the patient experience evolve within your time within urgent care?
Yeah, that's a great question. Within our organization, from the time that I started, there has always been a very large focus on um, patient satisfaction as well as other measurable health outcomes. And so I'm really thrilled to be part of an academic organization that is so focused on patient-centered care. Um, in terms of changes that I am starting to see within the urgent care setting, I think we are starting to, by and large, as a group nationally, those of us in urgent care are starting to bring in and develop more awareness of patient-centered care and trauma-informed care. Starting to move a little bit more towards this patient-centered care model and a little bit away from the treat and street approach. Now, that's still going to vary setting by setting, but the goal would be that all told, we can get all organizations and certainly all of our urgent care organizations to be trauma informed. And this is particularly important in the urgent care and emergency room settings because we know that people with trauma are significantly less likely to have sustained regular access to healthcare or to seek regular access to healthcare. And so these folks do disproportionately access urgent care and the emergency room. And so it's really important to understand that we are going to see a disproportionate number of these patients, and we need to be highly sensitive to that. We need to make sure that these folks who already feel like they can't trust care and will only seek care as a last resort still feel safe to continue to do that and hopefully can develop more of a safe and trusting relationship with the medical system that they may even consider seeking more regular care in the future.
Yeah, it's truly the front door for a lot of people into the healthcare system.
Absolutely, it is. I can tell you that one thing I've seen change over the past few years, which has been exciting and in some ways speaks to trauma-informed care, is now that we have so much more availability of virtual urgent care and telehealth. I've actually had many, many, many of my telehealth patients and my in-person urgent care patients disclose either trauma that has made it hard to seek care because of something that happened within the medical setting or something that happened personally within a patient's life, but that they felt more comfortable seeking care over a telehealth visit where they didn't have to have a physical exam. Now, certainly, any one of us practicing in healthcare should never be forcing a physical exam on any patient that does not want one. And it's certainly my practice that it's a patient's choice whether they have any aspect of a physical exam. And I explain to them, the risks and benefits, the pros and cons of the different approaches. And so I think the willingness of people to approach things from this harm reduction model can really make a big difference in the way that care is evolving within the urgent care setting.
Yes, I absolutely could see that. And aside from telemedicine, have you seen the patient experience evolve in different ways?
I have. I think that this is a fascinating question, I think. Essentially, what I am taking away these days is that the patient experience that I'm seeing reflected back has by and large been that the pandemic has made life harder. It has put major stressors on our healthcare system. More people are without primary care providers than ever before. We don't have a lot of great options on the horizons. And so the patient experience in urgent care has changed pretty dramatically because of that. It changed first because people didn't have access to their primary care and specialty providers because of the pandemic, because a lot of places were closed and not seeing their own patients or only seeing them over telemed. And now, because so many providers have left the field and so many people went without care for those few years, that we have this huge catch up situation. So we're stuck in this experience where people can't get access to primary care. People are frustrated by 24-hour wait times at the emergency room. And people are quite frustrated that the urgent cares are at capacity or have 4-hour waits. And I completely understand that frustration. I feel that our patients deserve better. I wish that I could give them better. But I think by and large, I'm seeing things become more and more frustrating for patients, unfortunately. And again, I think that means that all the more we need to be focused on patient-centered care and trauma-informed care.
Yeah, absolutely. Um, do you think there are any, again, sorry, going off script here a little bit. Do you think there are any specific ways that we can combat that
That's a great
frustration that patients are experiencing?
That's a great question. One of the ways that our organization has been working to mitigate that and meet patient needs was the development and expansion of our virtual urgent care platform. For example, our organization has 7 centers that are open, brick and mortar centers for 12-hour days, 7 days a week. We expanded to offer virtual urgent care, which also allows for 16 hours of on-demand virtual online urgent care per day, 7 days a week. And so when a patient comes into our urgent care center and is told that the wait time will be 2 hours and expresses frustration about this, the staff at our front desk has been trained to discuss with the patient whether they might be appropriate for a virtual urgent care visit and to give them that contact information. And so that can help some patients. I've had many, many patients reflect to me on virtual urgent care how grateful they were that they didn't have to wait for 2 hours. They could access the video briefly, from their home. They didn't have to get childcare. Things like this have made it a lot better for people in a lot of ways. And so I think that as organizations and as individual clinicians, we really need to be thinking about how can we provide safe, evidence-based healthcare for patients, but also really work to meet busy, busy people who are stretched way too thin where they are. And so I
Mhm.
think virtual urgent care and telehealth may be one way that we can expand that. I think other things we need to be looking at one of the things that I do in my own personal practice of urgent care is I'm looking for people who don't have a primary care provider and then looking to give them options to get them hooked up with primary care so that they don't feel like they need to come to urgent care for high blood pressure medication management, or they're really getting the appropriate chronic care follow-up that they need, and they have someone to connect them with healthcare maintenance and things like this. So I think taking an extra minute or two to work to make sure people have primary care and other supports and referrals is huge, because you can certainly operate in an urgent care setting that's independent, that doesn't really do referrals anywhere, and that just kind of treats patients. And I don't say there's anything wrong with that, but I think that the state of healthcare in the US presently is not really going to bear that model much longer.
Well, also
And
the
I think we
more,
really,
oh,
yeah,
go
go
ahead.
ahead.
No, I think the more trust that you can build with a patient in having those conversations also goes a long way and is helpful for them to want to return to see you again if they have any urgent needs.
Yeah. Yeah, that's exactly it. And I have had many patients come back and see me more than once. And I have seen, multiple patients more than once for things that I can't even necessarily help them with in urgent care, but they trust us or they trust me. And so they've come back, right? And so then my role is bridging them to, whoever I need to be connecting them with that will get them the care that they need.
Right.
And those relationships are so important, as you say.
Absolutely. And you may have just answered it, but I was wondering if there's anything you feel is coming next in patient-focused care.
My hope is that we see patient focused care um transformed or merged in a way with trauma informed care. And so I'd really like to see this patient-centered approach. I'd like to see trauma-informed care. I'd like to see acknowledgement of um, structural isms and phobias and things, all of this kind of combined into one model or one framework with which all healthcare providers are providing care. And so that's something I'm actually really committed to further researching and developing. And I hope if it's not me developing it, that one of my colleagues out there in the world will be developing this new framework.
Clearly, you are passionate about your role in urgent care. You're passionate about the care you can provide. So, if anyone is listening to this and might be considering working in or switching to working within urgent care, what would you tell them or what advice would you give them?
Yeah, this is such a good question. Anyone who is considering a switch to urgent care, I would definitely recommend an intensive urgent care training package and procedure skills training, either prior to or during your very early days of that new role. I would also recommend advocating for and looking for roles with strong support and mentorship, especially at the start. It's definitely its own specialty. Urgent care is fun and exciting with no 2 days exactly alike. I feel lucky because I'm in a group that sees a mix of bread and butter urgent care stuff with higher acuity, more complex, often psych mental health cases as well. I really enjoy that mix. I like seeing more straightforward cases and more complex cases. Some people prefer to only see typical bread and butter urgent care cases. So this is something to think about when you're thinking about what role and setting you're taking an urgent care position in. And then I think the other things to think about that can be really important are um, kind of coming back to some of the stuff we were just talking about with making these connections with patients and connecting them to resources and things. Some people can become quite frustrated by the limitations of their urgent care setting or the group with which they're working. So it's important to know your preference. Do you want to be a part of a big system with referral capabilities, lots of diagnostics, things like this? Or do you want to be a part of a standalone entity that doesn't really have a lot of community ties and resources, that, kind of your role ends at the end of the visit and there's not really much follow-up that you're involved in for your patients? And maybe that allows you to see more patients in a day. And you prefer to serve the community in that way, right? And then I think the last thing to really be mindful of is that it's so important to find balance no matter what field we're in. And it's so true in urgent care, which does not stop. Urgent care doesn't stop. People just keep coming all day until you close the doors and turn off the lights.
Hmm.
You can easily go 12 or more hours without drinking a sip of water or going to the bathroom or even charting if you let yourself. But think about whether that's the life that you want, right? Does your job actually require that? And if it does, is that really a trade-off that's worth it to you? For most of us, that's not going to provide an appropriate work-life balance, right? And so thinking about whatever job change you're thinking about, is it going to allow balance and self-care? Because we know that part of trauma-informed care is self-care and watching for burnout, right? And making sure that we are healthy so that we can serve our patients appropriately.
Yeah, that's very important.
Yeah. Yeah, it's huge. It's part of mandatory training in nursing and nurse practitioner schools now on self-care and burnout. And it's because patient outcomes go down, patient satisfaction goes down, provider depression, anxiety, suicidality goes up. People are leaving the field in droves like never before. So it's really important.
Yeah, it really is. So, switching gears here at the end a little bit, are there any current trends you're seeing in patient visits at this moment?
I think for the most part, what I'm seeing is fairly typical of this time of year. We are, coming out of a very robust flu, RSV, and COVID season. We're not all the way out yet, but we're moving there. And so, predictably in this area, where we are in New England, in the Boston area, this time of year, with the cold and with everybody being stuck inside, and at school and at work again and not masking, we saw a ton of viral illness this season, which is typical. And then I think the other thing that we saw quite a bit of this year was a pretty significant uptick in flu. And so that's certainly a little bit different from the last few years. We always see a big uptick in flu this part of the year, but it seemed disproportionate this season, at least in this region.
Yeah, I just anecdotally, everybody had flu that I knew, that I know. Um, yeah, it's been a crazy respiratory season.
The other thing that I'm finding exceedingly interesting, and I can't wait to see what's going to come down the line, is, since we started doing at-home COVID testing, we've started to do many other at-home tests, right? And so many of these medical diagnostic testing companies have developed at-home tests for COVID, flu, strep, UTI, all kinds of stuff. And so it's very interesting navigating that as a healthcare provider. Um, and trying to figure out, okay, well, what brand was the test? How much weight do we give to this test? Am I seeing this person in clinic or over video? Does their history line up? Should we test again? So this is a really new trend, at least in the urgent care setting. I imagine in primary care that they're seeing as well.
Yeah. Is there anything else that you want to touch on before we wrap up here, Meg?
Yeah, I think the only other thought that I had on this was that I've been really excited to be able to offer help from a harm reduction perspective through the urgent care setting. Um, and I hadn't originally thought that that would be something that I would really come across, but I'm finding that it's coming up more and more. And I can give you an example. When we think about healthcare, we think about what does the science say, you know, um, and so let's say, for example, someone has a kidney infection, right? And we know that that kidney infection is caused by bacteria, and we know it's not going to get better unless we test for the type of bacteria, treat with the appropriate antibiotic, push fluids, and flush things out, right? Um, so we can have that information. We can know that that's what the science says. But what if we have someone who's not able or willing to kind of meet those criteria or check those boxes, right? So, for example, I recently had a patient who called me from the bedside of a family member. They were literally in the hospital room of their family member, calling me on virtual urgent care. And the patient that I was meeting with had a problem with their immune system and very clear symptoms of kidney infection and had just been hospitalized with a kidney infection the month before. This was really worrisome to me. This is someone that I wanted to go straight to the emergency room, get vital signs, labs, and start getting treatment right away, probably admitted for a couple of days, with concern that their life may actually be in danger if they didn't because of the problems with their immune system. This patient felt that there was absolutely no way they could leave the bedside of their loved one and requested that I send antibiotics for them. We discussed the risks and benefits of that we wouldn't have the data we needed, that oral antibiotics may not get this well enough in time for this patient, that there was still risk for death, and that I still recommended an ER visit. But ultimately, I sent the antibiotic prescription so this person could start antibiotics, right? And so there's really this beautiful meeting patients where they are and being able to help patients in really difficult scenarios, um, and help them with harm reduction. And that's been this really cool experience that's come up many, many times since entering urgent care that I just didn't anticipate.
Yeah, I can imagine that is extremely rewarding as well.
Absolutely.
Yeah. Thank you for that. Um, and before we go, we do wrap up each episode with kind of a neat or a fun little story that our guests bring us. So, do you happen to have a story that you could share with us today?
I did bring a story. So this story is a constellation of multiple cases that I saw back when I was a veterinary technician. And I'll explain why I'm telling a story from that time at the end. So I worked in the emergency room for many, many, many years as a veterinary technician. And one of my roles was to triage any incoming patient. And so a patient would come in, come to the front desk, say, "Hi, I'm here with my dog for X, Y, or Z." And one of the veterinary technicians would go out and assess the patient. And we would decide on level of urgency, any diagnostics or other treatments we wanted to get started, get the provider's permission, and then we'd get that going, right? So similar to a human emergency room. Often we would have a waiting room full of people. And so every once in a while, we would get a complaint where a person or a couple would bring in their male cat because they found a breast mass or a lump on the mammary tissue. When I would ask them to show me the lump and I would investigate it as the veterinary technician, I would find that the tissue that they were referring to was normal nipple tissue. And so I tell this story because it was my very favorite emergency to see and treat in veterinary medicine was the incidental finding of a male cat nipple because it's a very normal anatomical finding, but not everybody's familiar with it. And people would come in so concerned, and it was just such a happy, easy fix that people could leave happy, knowing their pet was healthy and there wasn't a concern there. And happy endings are always my favorite.
That's incredible. And a story I'm sure that they tell probably the rest of their lives.
Yeah.
Oh, that's so good. Thank you for sharing that. Do you have any final thoughts for us, Meg?
Yeah, I mean, the last thing I would say, thank you, of course, again, so much to the UCA and Sam for having me. I'm so grateful. What a fun opportunity. And I just want to encourage everybody, anybody, patients, staff, administrators, providers, to look further into trauma-informed care. Patients should know that they should feel free to request these changes in their organization, and with their provider and team. And I just really encourage people to remember that these are tiny changes we can often make that can just have such a massive impact on patient experience. So they really are kind of low investment to high return. It can impact whether the patients will ever seek care again, will seek care from the same group or provider, and how patients implement their care and feel about their care. As healthcare providers, none of us wants to cause trauma. It's really a matter of remaining open to understanding what trauma-informed care is and how to make those small changes. If anyone is looking for more information, I would recommend searching on your preferred search engine for SAMHSA, SAMHSA, Trauma Informed Care, for more information. There's an extensive PDF text put out by SAMHSA on trauma informed care and tons and tons and tons of resources out there.
Yes, thank you for your time, for all of the information you've shared today, and giving us a lot to think about if maybe these things aren't being implemented in a current organization. So thank you so much. And listeners, thank you for listening in, and we will talk soon. Thank you.